So based on our clinical findings, history and histopathological examination, our diagnosis was borderline lepromatous leprosy with erythema nodosum leprosum, right foot trophic ulcer with right tarsal and metatarsal osteomyelitis, most probably due to distal polyneuropathy, with other diagnosis will be peripheral vascular disease and anemia of chronic disease with doubtful type 2 diabetes mellitus and asymptomatic incidental cholelithiasis. Coming to review of literature, leprosy is a chronic dermatological and neurological disease which results from infection of a unculturable pathogen, Mycobacterium leprae. Leprosy incidence has been decreasing in recent years due to introduction of MDT, and 2021 data of India shows a prevalence rate of 0.4 per 10,000 population with annual case detection rate of 4.56 per 10,000 population. And out of these, 58.1% of population had multibacillary leprosy and 2.41% had visible deformity at the time of diagnosis. And the pathogenesis, spreading, incubation period, everything is debatable in the Mycobacterium and the leprosy. And the peculiar characteristics of this pathogen is neurotrophism and dermatotrophism. The inter-individual variation in clinical presentation of the leprosy is due to the ability of the host to mount cell-mediated immunity to the pathogen. So depending upon the cell-mediated immunity, patient can present in variable phenotypes. And there have been many classification to classify these. First was Madrid classification, which was introduced in 1953, which has been obsolete now. And the next is Ridley-Joplin classification, which is in use since 1962. It has main 5 types of leprosy, from tubercular leprosy, borderline tubercular leprosy, borderline leprosy, borderline lepromatous leprosy, and lepromatous leprosy. And in these are the 2 poles with spectrum in between. Towards tuberculoid leprosy, patient presents with single lesion, single thickened nerves, and the lesions will have well-defined borders. And towards lepromatous leprosy, patient will have multiple skin lesion with multiple thickened nerves. And patient will also have glove and stocking anesthesia similar to our patient. For diagnosing leprosy, full thickness skin biopsy with HE stain and White-Marco stain in active lesion is the gold standard and investigation of choice. But since it takes time, the mode of diagnosis can be used, and most commonly used is slit skin smears, which has sensitivity of 10 to 50% in various studies and almost 100% specific. To identify the latent Mycobacterium leprae infection, various other diagnostic modalities have been used. In that, immunodiagnostics, for cell-mediated immunity, the lepromin test, which was used before, has been obsolete now, and research has been going on for serology for PGL1 by ELISA, which has 63.8% sensitivity and 91% specificity, but it fails to identify active lepromatous leprosy, and it has a positive predictive value of around only 4 to 10% in various studies. And even PCR can be used, which has sensitivity of more than 90% and almost 100% specific, but it is not readily available for the diagnosis. Coming to lepra reaction, since after introduction of MDT, leprosy cases have been in decreasing trend. Now the focus has been towards the lepra reaction. There are mainly 2 types of lepra reaction, type 1 and type 2 reaction. Type 1 is also known as reversal reaction, and type 2 is also known as erythema nodosum leprosum. And there have been rare reaction known as Lucio phenomenon. It is seen in South and Central American region in diffuse lepromatosis. Type 1 reaction is usually seen in borderline spectrum disorder leprosy. Here the previously existed skin and thickened nerves became inflamed and tender. There might be new onset nerve involvement also in this reaction. In type 2 or erythema nodosum leprosum, new red, painful, tender, cutaneous or subcutaneous nodules can be seen, and new onset nerve involvement with systemic involvement like fever and other symptoms can be seen. Erythema nodosum leprosum is an immune-mediated inflammatory complication of leprosy. Though the mechanism of action is debatable, it is mostly due to type 3 hypersensitivity reaction due to formation of immune antibody, antigen and antibody complex, which is deposited in various regions. Incidence is around 50% in lepromatous leprosy and 30% in borderline lepromatous leprosy in pre-WHO MDT era. Data is insufficient in the recent era. Risk factor for erythema nodosum leprosum is female more than 6 skin lesions and more than 3 areas involvement, and hormonal changes like puberty, pregnancy and lactation in females. And natural causes, it is resolved in most of the patient, it resolves itself in 1 to 2 weeks in most, and it can be recurrent and chronic in 30% of the patient which used to be dead. This is a study conducted, it's a very good study conducted by PGI Chandigarh, where around 1,500 multiple ciliary patients and around 1,150 patients were involved. It took place from 1884 to 1898, where it was a study duration was around 15 years. Here we can see reversal reaction usually takes place in paucibacillary leprosy compared to multibacillary leprosy. As we go towards lepromatous leprosy, reversal incidence of reversal reaction decreases, and erythema nodosum leprosum patient is usually seen in multibacillary leprosy. Reversal reaction usually takes place within the 6 months of starting of MDT, and erythema nodosum leprosum takes place within 1 year, and even it can prolong due to chronic and recurrent cases of erythema nodosum leprosum. And there is another study called as ENLIST trial, erythema nodosum leprosum international study trial, which took place in various countries, India, Nepal, Ethiopia, Brazil, where most of the leprosy cases are found. It involved 292 patients, and in these patients, pain is the most prominent finding. In this patient presented with pain in the skin, that is tender nodular lesion, and pain in joints in 36% of the patient, and pain in both bone, digits, muscles, eyes and other structures. After pain, fever is the most predominant symptom in 74% of the patients, and skin lesions are the next predominant findings, and other findings are malaise, localized peripheral edema, insomnia, and even patient presented with depression due to the skin lesions. In skin lesion, nodular lesions are the most common findings in 91% of the patient, and patient might present with other type of skin lesions like papules, bullae, pustules, and even patient presented with erythema multiforme like lesions in around 1 to 2% of the patients. In organ involvement, patient presented with edema in around 52% of the patient, followed by nerve fiber involvement, that is functional nerve impairment, in around 50% of the patient. Coming to treatment of the erythema nodosum leprosum, in mild erythema nodosum leprosum without any neuritis, ulceration and other systemic symptoms, it can be dealt with supportive care and symptomatic management with antipyretics and painkillers. In severe patient with neuritis, ulceration and systemic involvement, patient should be treated with corticosteroids, 40 to 60 mg of prednisolone, which is tapered over 2 weeks. And in patient with chronic or recurrent lesion, we can use methotrexate starting from 7.5 mg to 20 mg once weekly, and clofazimine 300 mg daily, and we can thalidomide can also be used 300 to 400 mg, which can be tapered to 100 mg every few months. It has been found that thalidomide, the patient who have been started thalidomide has dramatic response for erythema nodosum leprosum, which patient becomes asymptomatic within few days. Coming to treatment of leprosy, there is MDT recommended by the WHO. Patients are classified into two classes, paucibacillary and multibacillary. In paucibacillary patients, patient should be given rifampicin 600 mg once monthly, that is supervised, along with dapsone 100 mg daily, which is self-administered. In children, it is rifampicin 450 mg once monthly with dapsone 50 mg daily. In multibacillary leprosy, rifampicin 600 mg once monthly supervised and clofazimine 300 mg once monthly and 100 mg on alternate day or 50 mg daily self-administered, plus dapsone 100 mg once monthly supervised plus 50 mg daily self-administered. Coming to our one of the clinical findings, saddle nose. There are multiple differential diagnoses. Saddle nose can be due to infectious, inflammatory, and malignant causes, and other causes like trauma and drug abuses like cocaine, and in iatrogenic surgical causes. Infectious, syphilis is the most common cause for saddle nose, along with then leprosy, cutaneous leishmaniasis, and TB and septal abscess. Inflammatory causes like GPA, relapsing polychondritis, and sarcoidosis can also have saddle nose deformities. So in leprosy, 95% of the patient with lepromatous leprosy have nasal mucosal involvement. So this patient can also have anosmia, epistaxis, and atrophic rhinitis. The mechanism of saddle nose is damage of the nasal mucosa, which causes mucosal disintegration and exposure of the underlying cartilage, which undergo necrosis and subsequent septal perforation. So this resorption of nasal spine and development of which leads to development of the saddle nose. So the take-home message of today's CPC is erythemonodosum leprosum can present as painful skin lesion with new onset systemic symptoms like fever and worsening skin neuropathy, and edema, arthritis, uveitis, etc. Another systemic findings. And when you find swollen hand and feet syndrome with erythemonodosum, please palpate the nerves and think of leprosy instead of finding other before thinking other diagnosis. Thank you everyone.
So very good effort by residents of medicine department. Just for the benefit of resident, I would like to inform about the sequence of CPC, how we usually present the CPC. So first, we have to present the history examination and investigation except biopsy and the FNAC, right? And based on all history examination and rest of other investigation, you have to write down the differential diagnosis, and then you discuss these differential diagnosis, points in favor, points not in favor, right? And then we can invite the comment from the audience, okay? And after that we can go on to the pathology, and so that they can discuss the FNAC or histopathology. Then after that again you invite the comment from the audience, and after that because these patients basically you put on treatment, right? So you can discuss after that the treatment of various options available and what treatment has been given to that particular patient, right? And if available, then you can also show some picture of the follow-up pictures of follow-up, how the patient responded to the treatment. So that should be the the sequence for the students. Thank you.
Patient, when she was admitted before, 1 year back, here she was not treated here, no? Somewhere else. She was treated as diabetic patient and she was put on OHA. So what OHA was given, it was not mentioned in the case at all. And one thing, is the OHA after diagnosis of leprosy, are you continuing with that? And second question, HbA1c you said was not done any time. So why not? Previously also, maybe it was done, you have not inquired. This is my comment. So, reply please.
Regarding the question is that actually one thing was what was the OHA? So history-wise actually
हमारी आवाज आ रही
the OHA which she was actually told she did not know the medication which she was taking. And it was only one tablet which she used to take for 2 months. She was taking this OHA. So regarding the query of diabetes, like usually when we have a doubtful diabetes history, so we ask the patient if she had remembered any of the she can recollect the blood glucose values which she had. So according to her and her
Actually, in summary, it is written that she was on
OHA for 2 months. Discharge of surgery also she was not put on OHA because her glucose levels were normal. And in our diagnosis, after our diagnosis also we did not continue OHA because the blood glucose charting showed was completely normal during the entire hospital stay. So coming to the treatment which we have done, she is due for follow-up. She was discharged last week and she is due for follow-up in this week. She will be followed up with this week and she was discharged on corticosteroid 30 mg, that is 30 mg prednisone and multivitamin.
regarding the LVMS.
Madam, on podium.
That will be better.
Probably during the time she was admitted with us, the HbA1c was not being done in our hospital.
It was here only, no?
Yeah.
It was not done, but before also.
There was no records available. There were no records available of that patient. And moreover, when the charting in hospital was done, and before that also she was admitted in our hospital in surgery department, the charting was normal. She did not had any stigmata of diabetes, like her fundus was normal. There was no evidence, and the charting was normal, so it was not required actually. Otherwise, if we had a diagnostic dilemma or it was very must, then we could have got it done from even outside. Sometimes we do it if it is very necessary, but we had no doubt that she still has diabetes. Probably that's why it was not pursued.
Why I am asking, just a minute, why I am asking this question, that are we giving unnecessary drugs to the patient, and what are the after effects of those drugs to the patients for the development of some new disease? That is why.
No, the OHA will not result in the disease which she has presented. Yes, you are right. We are over-diagnosing and over-enthusiastic in treating the patients without taking the proper history and doing the clinical examination, because most common cause of having an ulcer on the foot, people think that it could be diabetes. So maybe one reading was there of sugar high because of some, just the khana tabhi khaya hoga and the sugar must have been taken. Whatever was the reason for that one single raised blood sugar level, and she was labeled as diabetes. So one more important thing, that a single reading of raised sugar does not mean diabetes. So that we have, before labeling any patient with diabetes, please rule it out, because once a doctor diagnoses a diabetes, then the person becomes diabetic throughout their life, and we take every, because diabetes is also a systemic disease, and we relate everything to diabetes. So we may sometimes miss very important diagnosis.
For the residents, I think I thank the medicine department for bringing up a case like this, because in our neurology we are seeing many cases, and leprosy is one of the disorders which is missed for decades. Leave days or months, it is missed for decades. So literature will tell you that probably the delay in diagnosis is almost of 13 years, 15 years in few cases. So I think probably this is very important. The last line you wrote is probably needs to be added something, that a detailed neurological examination has to be done, not only palpating the nerves. So that is important. And in neurology you have only history with you and examination. Otherwise you will be wandering always in a big forest. So I would suggest that probably you do a detailed neurological examination. Of course, nerves palpation comes into that. So I again thank the medicine department for bringing up this case.
Any other comment? Yes, ma'am.
Yeah, this is just for the conduct of the CPC. Did you manage this patient? Yeah. So normally in CPC what happens is you work up a case, you have an interesting case, and the treating department knows the histopathological diagnosis also. So we give this case to another unit, PG or SR or faculty, whoever. They work up the case, they come out with a differential diagnosis, which is discussed by the histopathologist. So the person who's presenting the CPC should not know the histopathological diagnosis. That's the beauty of a CPC, not the treating physician. Right? So this is how we used to conduct it at UCMS. So I don't know PGI what it was. So maybe that can be looked into and give it to another unit SR who has not actually managed the case, but you give him the findings, maybe withhold 1 or 2 findings, which you think is very obvious. And then finally it is discussed. So they should not know the histopathological diagnosis.
Actually, it was done on very short notice, I think so, and they have prepared it very well. So I congratulate all of you. Madam is online with us. Madam, any comment you want to make?
Hello?
Hello.
Am I audible?
Yes, ma'am.
Yeah, so I really enjoyed this case presentation, which was, of course, in the CPC format, but I've never seen, this kind of presentations. We thought that leprosy has been, not that common, but certainly this was a very good demonstration, and I think for student CPCs, this format is quite good, that you present the case, but after that one needs to have some discussion and keep the diagnosis a little secret, and then after the discussion we demonstrate the histopathology, and after that again we have a discussion about how diagnosis could be made earlier, and then of course one can cover a part of management, which is of great use to the students and residents. So overall, a very nice experience for this teaching session. I think we should follow this format, and I will congratulate the Department of Internal Medicine for presenting such a nice case. Thank you. I was not able to be personally there because I'm traveling. I'm just going to be back after some time, and I wish all of you a very happy Teachers' Day.
Same to you, ma'am. Thank you so much.